Good morning, everyone. Thank you so much for joining us today. We're just going to give everyone a moment or two to log on and we'll begin shortly. Okay, good morning, everyone. Thank you for joining us today. We are so pleased to present the Weill Cornell Medicine and New York Presbyterian Kidney and Pancreas Transplant Program. Conversations with Cornell Kidney is a 6-part virtual education series for patients, caregivers, and our transplant community. For Conversation 5, we will discuss post-transplant medication. Our speakers today are Eliza Bensley, who is the clinical transplant educator, and Giovanna Codespoto, who is the pharmacist. It is my pleasure to turn things over to Eliza and Giovanna.
Thank you, Eliza. Giovanna, take it away. We're really lucky to have you here. I'm so excited for this presentation. Everyone, please ask questions through the chat box. We are so lucky that we have this valuable resource, and she's going to be able to answer medication questions for us. Thank you.
Thank you both. Okay, hi everyone. So my name is Giovanna. I'm one of the kidney transplant clinical pharmacists at Cornell. And today we're going to talk about our immunosuppressant medications and their side effects. All right, so first we'll start with why do we need medications? So our bodies are very smart, and our immune systems have been designed to protect our body from foreign material. So whether that be from infections, from bacteria, viruses, or fungus, from abnormal mutated cells like cancer, and even a transplanted organ. Your body recognizes all of that material as foreign and then protects the body by attacking and killing those cells. However, in the context of an organ transplant, that can lead to rejection of the transplanted organ. So in turn, we have to use medications to weaken the immune system and prevent the body from attacking the transplanted organ. I like to think of the medications that you'll be on post-transplant in 3 different sections. The first one are our anti-rejection medication, or our immunosuppressants. The next are our anti-infection medications, or prophylaxis. And then the second or the third piece of the pie is all of the other medications that keep you healthy. So we'll start with the first slice of the pie, our anti-rejection medicines. So these medications are used to prevent rejection and damage to the kidney. Patients generally will be on 2 or 3 different anti-rejection medications, and that's determined based on patient-specific factors. As time progresses after your transplant, your risk of rejection does decrease over time. So the doses of your anti-rejection medications become lower. However, you will always be at risk of rejection, so you must always stay on these anti-rejection medicines. Our anti-infection medicines are given to you to prevent potential infections because your immune system will be weaker. All patients are started on 3 different anti-infection medications, so medicines that cover viral, fungal, and bacterial infections. However, like we talked about on the last slide, as your anti-rejection medication doses are decreased over time, your risk of infection becomes less because your immune system becomes a bit stronger. So because of that, and the decreased risk of infection as time progresses, all of your anti-infection medicines are stopped by 1 year. However, because you'll always be on anti-rejection medicine, you will always be immunosuppressed. So it's still important to take certain precautions after transplant. And then the third piece of the pie is all of the other medicines that keep you healthy. So you might be started on medications to manage high blood pressure, high blood sugar, and then we also continue some of your medications from before transplant, depending on what those medicines were for. You will get explicit education and directions as far as what medicines will be continued and which ones you'll no longer be taking. at the time of discharge. Now we'll jump into some important general information and medication tips. So your medicines after transplant are very important. As we know, they're required to keep that transplanted organ healthy, to keep it protected from your immune system. Patient education is very important. So you are all taking the first step right now by coming to these pre-transplant educational workshops. And at the time of discharge after your transplant, you'll also meet with one of the transplant pharmacists, so either myself or Hannah, and we will discuss with you your transplant medications. It's usually like a 45-minute to an hour-long session where we talk about medicines and fill a pill box with you. Being that this is a complete change to your medication routine and regimen from before transplant, it's important that you study up on your medicines afterwards so that you know certain things about your medicines. So patients should know the name of your medicine, both the brand and generic name, the purpose of your medicine, so why you're taking it. Is it for rejection, for infection, and then how to take it. So what is the correct dose, the amount of milligrams that you're taking, as well as the number of tablets and how often you take them. Compliance after transplant is very important. Every time that you take a dose late or you miss a dose of your medication, you give your body a chance to make cells and antibodies to fight off that kidney. So your medicines should be taken always as prescribed, and you should never intentionally skip or miss a dose. Even in 10 years from your transplant, you're feeling great, you're making a ton of urine. If you stop taking your anti-rejection medicines, your body will start to reject the kidney. Your refills for medicines should also be filled on time. So you should be very diligent about making sure you're following up with your pharmacy to make sure they have prescriptions for you and that they'll be given to you on time so there's no lapse in your therapy. We tell patients to call your pharmacy for refills a week ahead of time so they have time to work on ordering your meds or working through insurance problems, calling the doctor. It's never advisable to wait until a couple days before you run out of medicines, just in case something were to happen, because we don't want you to go without pills. And then you should always carry an accurate medication list with you, especially when you're going to a doctor's appointment, whether that be your clinic appointments post-transplant at Cornell Kidney, or when you're going to other doctors so you can show them your medicines. These medications have a lot of interactions. So drug interactions, specifically the transplant medicine, so the anti-rejection drugs, can have very significant reactions with prescription medicine as well as over-the-counter medicines. And the reactions can be severe and could potentially cause harm to you or the kidney if we don't address those issues before you take the medication. So you should always call the transplant team before you start any new medicine. So whether that's a prescription medicine from your cardiologist or your endocrinologist, you call us first, as well as over-the-counter medicines. So before you start anything, whether it's herbal supplement, vitamin, or just an over-the-counter medicine. And then the third bullet here, you're not to be taking herbal supplements or dietary supplements without permission from the transplant team. As far as pain medications, the only safe over-the-counter pain medicine is Tylenol or acetaminophen. You can use the extra strength or the regular strength Tylenol as long as it's just plain old acetaminophen in it. All other over-the-counter pain medicines are not safe for the new kidney after the transplant. So that includes ibuprofen, so Motrin or Advil, as well as naproxen or Aleve, and full-strength aspirin. Just like there's interactions with medicines, there's also interactions with foods. So we advise you that you should not be eating or drinking any grapefruit, pomegranate, or star fruit after the transplant. Most people are familiar with some of the drug interactions with grapefruit because there's interactions with some more common medicines, but we're a little bit more strict after the transplant. So that goes for eating the actual fruit of those 3 fruits, as well as fruit juices and fruit extract. So there's some examples on the slide as far as different drinks that may have fruit juices or fruit extract. So like Sunny D, the citrus drink has grapefruit juice in it. Grapefruit LaCroix has grapefruit extract. Fresca also has grapefruit juice. So all of those things should be avoided. Any other fruit or vegetable juice is fine. And there's some examples here. Your other citrus fruits are okay. We talked briefly about the role of the transplant pharmacist, but after transplant, everyone will receive medication education with a transplant pharmacist. And we do encourage you to have some support person with you that will be involved in your post-transplant care. It is a lot of information to go through, and it's usually an overwhelming session because it's such a big change from what you were doing before transplant. So it's encouraged to just have a second set of ears there to listen. Everything we'll go through will be written down for you, so you can always refer back to it. And then you'll see the transplant pharmacist as needed in the clinic if you have other questions as well. Usually that education happens on either the day before or the day of discharge, and we'll give you that final medication list and then fill that pill box with you. So this slide details exactly what you'll find on this medication schedule or the medicine list. So this is your new holy grail when you leave the hospital. This list is going to have explicit instructions on how you take your medications. It will have the drug name, both the brand and generic, the strength, the purpose, the dose, and the time that you'll take it. And this list is comprehensive of all the medications that you'll be taking after transplant. So that includes medicines that you were on before the transplant that we'd like you to continue. If the list does not contain a medicine that you were taking before transplant, that means you're no longer taking it. This list should be followed explicitly for filling your pill box. So you should never follow directions on your pill bottles when you fill the pill box. That's opposite of what we've always been taught. We've always been told that the labels on those pill bottles from the pharmacy are the most accurate. You follow those directions. However, post-transplant, we see you in clinic 2 to 3 times a week, and we make dose adjustments to your medicines very frequently. And we do not send a new prescription every time that we change the amount of capsules that you're taking. So because of that, the directions are more than likely outdated. So sometimes patients like to take Sharpies and Sharpie out all of those directions. So the bottle just says the name of the medicine, the strength, and then other pharmacy information, but there's no directions to even tempt you. You'll get updated copies of the list when you come to your clinic appointments. So you should always make sure you're bringing the most updated copy when you come to clinic or you go to a different doctor's appointment. This is an example of what a list looks like. So this example list has 3 different anti-rejection medicines here: mycophenolate, prednisone, and tacrolimus. And then you can see the directions are listed underneath. So for the mycophenolate, it's a 360 milligram tablet. The brand name is written on the second line, so commonly known as Myfortic. And then the directions are underneath. Take 2 tablets by mouth every morning and 1 tablet every evening. And then we use this grid on the right-hand side that has different check marks and slots for morning, afternoon, evening, bedtime, because it will match up with the pill box that you'll be sent home with that will also have 4 slots for every day. So you just have to follow the numbers and the check marks on the list, and you plug the pills into the box. And you'll pill box 1 by 1 medicine to fill the pill box for the week. So at the time of discharge, you'll leave with a 30-day supply of your medications. That will be provided from one of the 2 specialty pharmacies that we work with. You'll leave with that updated medication list, and then you'll get some tools to measure your vital signs at home. So the blood pressure cuff, a scale, a thermometer, and then you'll also get that 7-day pill box. Now we'll get more into the nitty-gritty information about the transplant medicines. We'll first start off with the first slice of the pie, so our anti-rejection medicines. These medicines are used to prevent rejection and damage to the organ. They're also called immunosuppressants or immunosuppressant medications. These medicines, like we said, are for life and may consist of either 2 or 3 drugs in your specific regimen. So the examples of medicines that we're going to talk about today, one is tacrolimus, or Prograf is the brand name, mycophenolate mofetil or Celcept, and then prednisone. Most patients go home with 2 of the medicines, so prednisone and mycophenolate. Occasionally, patients go home with prednisone if they're deemed to be at higher risk for rejection, or there's another reason why your physicians wanted to start the prednisone. The first medicine we'll talk about is tacrolimus. So tacrolimus is the most important anti-rejection medicine. It is formulation-wise a capsule, and it comes in 3 different strengths. There's a 0.5 milligram, which is the yellow capsule, a 1 milligram, which is the white capsule, and then a 5 milligram, which is the red capsule. Everybody's body breaks this medicine down differently. So the doses that patients go home on and are started on vary widely. So we need to sometimes send you home with bottles for multiple strengths because you might require a certain dosage that you can't make with just one of the capsule formulations. It's a twice-a-day medicine, and it should be taken 12 hours apart. All of your medicines will be due at 9 a.m. and 9 p.m. for the first few months after transplant, just because it makes it easier for clinic appointments and drawing bloods. After that, you can talk with the kidney doctor as far as adjusting your schedule to fit your day-to-day life. But for right after the transplant, expect that meds will be 9 and 9. Prograf, as far as taking it with food, it doesn't necessarily have to be taken with food in order to be absorbed. But the most important thing is that you're consistent in regards to taking it with or without food. So if you're not a breakfast person, you normally just wake up and get on with your day, then you should take your medication always on an empty stomach. Versus if you like to eat breakfast, you should take your medicines either with or after you eat food, and that should be what you consistently do. So you shouldn't alternate. Some days you eat breakfast and some days you don't. The amount of the medicine you absorb is affected by if you have food in your stomach. So we can adjust the dosage of your medicine if you are taking it with food versus if you're not. So consistency is very important. Some people have no issues taking their medicines on an empty stomach. They have an iron stomach. Other people are a little bit more sensitive and get a little bit of heartburn or nausea after taking the pills with nothing in the belly. So it's really up to you. If you like to eat breakfast, I normally advise people eat something and then take your pills. And then the other important thing with Prograf is that because this medication is dosed from your blood work, and we measure how much of the medicine is in your blood and then decide if we need to increase or decrease the amount of milligrams that you're taking, it's important to be consistent with the manufacturer that you're using for this drug. So ideally, if you are always filling brand name Prograf, then that should always be what your pharmacy fills for you. Switching between generic manufacturers or back and forth between brand generic, all of the pills have slightly different concentrations of the medicine in it, very, very slightly. But because the medicine is watched so carefully in your blood work, flipping back and forth every month or so can affect the level of the drug in your body. So if you always fill the Accord brand, then that should be what manufacturer your pharmacy consistently fills for you. This slide is explaining some dosing examples. So what we could expect if your dose was 3 milligrams, you could take 3 of the 1 milligram capsules. If your dose was 2.5 milligrams, you would take 2 of the 1s and then 1 of the 0.5s. And then if you are on a higher dosage, you could take 6 of the 1 milligrams, or there is a 5 milligram capsule, so you have to take less capsules. So it would be 1 of the 5s and 1 of the 1s. We alluded to this before, but the medication is adjusted based on the level of the drug in your blood. In order to get an accurate level, when we draw your labs the mornings of clinic, you cannot take your medication beforehand. So your medicines, like we said, will be due at 9 and 9. Clinic appointments are early in the morning. They're at 7. So it will be too early to take your medicine anyway. You come in, you get your blood work drawn, and when it's closer to 9 o'clock, then you'll take all of your medicines. If you take the medicine before your blood work draw, the level looks very elevated, even though it's not, and we would have to repeat labs to get an accurate one. The dose changes frequently, and like we said, everybody's body breaks it down a little bit differently. But an example of what we would potentially do at clinic is you come in, we get your tacrolimus level, and the level is above the range we want it to be. That means that you're too immunosuppressed, so we would decrease the dose of pills that you're taking. Versus if the opposite were to occur, where your level is below range, that means that you're not immunosuppressed enough, so you're at risk for rejection, and we would then increase the amount of tacrolimus. As far as side effects go, the main ones that I like patients to be aware of, one is a tremor. Usually it's a hand tremor or hand shaking, and that usually happens when the level of this drug is too high in your body. So if you wake up one morning and you're much more shaky than your baseline, you call the clinic, let us know so we can set you up to either come in to get labs or send you somewhere close to home to check the level of the tacrolimus and make sure it's not out of range. Usually when it goes back down to the normal range that we like it in, the tremors should go away. Patients sometimes get a headache an hour or so after they take the medicine. It should be something that your body gets used to over time, and it should be dull that goes away with the Tylenol. Some patients over time do experience increased blood pressures, increased blood sugars, potentially trouble sleeping, confusion. The blood pressure and blood sugar we obviously will be monitoring and then adding medications if we need to. And some of you might be thinking, why is kidney damage on this slide, being that I'm being evaluated or on the list to have a kidney transplant? And that is a very valid concern. So tacrolimus over time has been shown to decrease your clearance, but very marginally. So maybe over the course of 10 years, your clearance decreases by 10 milliliters. However, tacrolimus is also the best medicine that we have for preventing rejection. So it is the gold standard medication across the country and really across the world for all organ transplants. Tacrolimus has the best probability of preventing rejection as long as we keep that goal level, or we keep your blood level in between the levels that we need it to be. So we know that over time it can cause some marginal kidney damage, but everything is a constant scale with kidney transplant of protecting the kidney, but also protecting you. So everything has risks and benefits when it comes to transplant. So the benefit that we get from tacrolimus is much greater than the risk of potentially causing a slight decrease in clearance over time with the use of this medicine. The next medicine that we have on our PowerPoint is mycophenolate mofetil or Cellcept. This is also an anti-rejection medicine that pretty much every patient will go home on. It comes in two different strengths. There's a 250 milligram capsule and a 500 milligram tablet. The dose is typically either 500 to 1,000 milligrams, and it's taken twice a day. So patients will either be on one of the 500 milligram tablets twice a day or two of them twice a day. This medicine is the medicine that can be a little bit rougher on the stomach. So if you do eat breakfast and you like to eat, then I would again say eat breakfast, take your medicines afterwards, because the biggest side effect is it can cause some stomach upset. So nausea, vomiting, diarrhea, heartburn, abdominal pain. But taking it with food helps to decrease these side effects. Diarrhea is the most common out of all of these stomach upset symptoms. So if you have more than 3 episodes of watery diarrhea, we tell you to call the clinic so we can test your stool, make sure we're not missing an infection or anything, and then we'll address the medicine here if we need to make some dose adjustments. This medicine is not dosed on blood work, so it will stay whatever the dose is that you were sent home on, unless there's a reason why we need to adjust the dosage. Patients can also sometimes have low white blood cell, red blood cell, or platelet counts. That's nothing you would feel. It's something we would see on your labs, and then again, adjust the medicine if we have to. Something unique about CellCept or mycophenolate with our anti-rejection medicines is that it has a very high probability of causing birth defects if you are to become pregnant while you take this medicine. So there's a warning on the medicine that women of childbearing age must be using effective birth control while taking mycophenolate and for 6 weeks after stopping. It is possible to have a healthy pregnancy after transplant, but that would have to be something that you're discussing with your obstetrician and your kidney transplant nephrologist to decide when the right time for that is. Patients would come off of this medicine and they continue to use effective birth control for 6 weeks until it washes out of your system, and then you can start trying after the 6 weeks. If you plan on becoming pregnant after your transplant, like we said, always tell the transplant team before trying because we need to switch your medicines around. And if you accidentally become pregnant, you should notify the transplant team immediately. This medication has a very high risk of spontaneous abortions or miscarriages. And then if the fetus were to survive, there's a very high incidence of birth defects. So anyone that's a caregiver of a patient who is of childbearing age should be wearing gloves when they're helping fill the pill box, if at all, because the medicine can be absorbed through your skin minimally. So we want to minimize any exposure. And then our next medicine here is prednisone. So prednisone is a steroid. It's used for a lot of different things. You pull a muscle in your back, you have a bad lung infection with a cough that your doctor wants to start you on a steroid. It's an anti-inflammatory medicine. We're using it to prevent rejection. Prednisone comes in various different strength tablets. Most patients, if you are sent home with prednisone, which is a small part of our patient population, you'll be sent home with 5 milligram tablets, and then we quickly taper you to get to 5 milligrams a day. So the doses decrease over time. And so your dose may consist of either whole or half tablets to get you down to either 5 milligrams a day. Sometimes patients are on 2.5 milligrams every other day. So it's a very minimal dosage. But like I said, most patients will go home without prednisone. We try to be prednisone or steroid sparing at this center if we can. If you are sent home with steroids, it's a once-a-day medicine, and we advise you to take it in the morning, preferably with food. As far as side effects go, some of us may be familiar with the side effects of prednisone. At high doses, we see more side effects. So upset stomach, weight gain, increased blood pressures, blood sugars, cholesterol, as well as mood swings, irritability. Some people have trouble sleeping. So because of this, and we know the side effect profile of steroids, we try to minimize the amount of steroids that you'll be on. Low dose, long-term use of steroids, the main thing that we're concerned about is bone loss or osteoporosis. So we would send you for your routine bone density scans to make sure we're supplementing your calcium, vitamin D, and giving you medicines to strengthen the bones if they are weaker. Next, we're going to switch gears now to our anti-infection medicine. So this is that second piece of the pie. These medicines are used to prevent potential infections. So this does not mean that you have an infection if you're on these medicines. It's just to protect you because your immune system is low. So patients will be put on a medicine medicines to prevent viral infections, bacterial infections, and fungal infections. And the amount of time that you stay on these medicines depends on certain factors, and the timelines are illustrated on the slide for you here. So the first medicine we have here is valganciclovir or Valsite. This one, think V for Valsite, V for virus. So patients take one tablet. It's a 450 milligram tablet. It's once a day, and it's stopped after 6 months. You will either be on this medicine or our next medicine here, acyclovir Zovirax. This is also an antiviral medicine. And the choice between which one we choose is dependent on if you've ever been exposed to CMV or cytomegalovirus, or if your donor has. Both of these medicines also help protect you against shingles and reactivation of any herpes viruses. Acyclovir is a 400 milligram tablet, and it's taken twice a day, so it would be morning and nighttime. And if you are on acyclovir, it stopped after 3 months. The Valcyte from the previous slide was 6 months. The side effect profile is similar between the two. For the most part, they're pretty well tolerated, other than the fact that both of them can have effects on the bone marrow and can potentially cause low white blood cell, red blood cell, and platelet counts. Again, that's nothing you would feel, something we see on labs and adjust your medicines as needed. So that's our antiviral medicine. And then next we have our antibacterial medicine. So this medicine is Bactrim, and we have the abbreviated generic name on the slide here. It's a combination of 2 different antibiotics, sulfamethoxazole trimethoprim. And that's why the dosage is written as single strength, and it has 2 different milligram doses, 400 milligrams / 80 milligrams, because those are the 2 different strengths for the combo of the antibiotics in the 1 pill. So the dose is 1 of those single strength tablets every day. And this one you'll be on for 1 year. So this is, again, an antibiotic. So think B for Bactrim, B for bacteria. It's used to prevent a few different types of bacterial infections, most notably a type of pneumonia that we can see in patients that have a lower immune system. And it also helps protect against urinary tract infections, which is helpful after you just get a new kidney. Side effects for Bactrim, because it is a sulfa drug, some patients do experience allergic reactions to this medicine, or they might have a history of having Bactrim in the past and have had an allergic reaction. If that's the case, we have alternative medicines that we give you that also protect you from these bacterial infections. Bactrim does make your skin more sensitive to the sun, so you need to make sure you wear at least SPF 30 and cover your skin with hats and clothing when possible. You'll almost get a rash if your skin is exposed to like UV light when you're taking Bactrim. However, being on anti-rejection medicine at baseline is going to increase your risk of skin cancer. So even though you're only on the Bactrim for 1 year, you should always stay vigilant about wearing your SPF and covering up, avoiding direct sunlight. And making sure that you're going for your yearly skin checks with the dermatologist. And then our last medicine, so we covered viruses, bacteria, and then last up we have fungus. So clotrimazole or Mycelex, this is an antifungal lozenge, and this is preventing an infection called thrush, which is an overgrowth of fungus on the tongue. Sometimes babies get thrush, people that use certain inhalers can get thrush, and people that have lower immune systems can also get it. So patients are instructed to use 1 lozenge twice a day. The medicine works by actually directly coating the area that we need the fungus to not grow. So it's a lozenge, you let it dissolve on the tongue, and then it prevents fungus from growing on the tongue, and the medicine also drips down the throat as the medicine is dissolving. Because of that, you cannot eat or drink 30 minutes after you use this medicine, because the medicine needs contact time on the tongue. It's usually on your list for around 2 to 3 months post-transplant, and then your doctor will taper you to just once a day, and then it will fully come off. This medicine, although some patients think, oh, it's just a lozenge, it's no big deal, it actually boosts the level of your tacrolimus, which is the main anti-rejection medicine that we measure your blood work for. If you intentionally skip or you forget doses here and there, it affects the level of your medicine. So this medication is just as important as taking your anti-rejection pills. That being said, when we stop this medicine, your doctors will carefully monitor the level of your tacrolimus to make sure that when you stop it, you don't bottom out for your tacro level because you don't have that booster anymore. So our key points to remember when we're thinking about our medicines is that it's very important to learn all the details of those new medications. You should always carry around an accurate medicine list because you'll get different medicine lists when you come to clinic. If you're readmitted for whatever problem, you'll get lists at the time of discharge. So always make sure you're pillboxing and bringing in that up-to-date list. Your medicines should be taken exactly as prescribed, and make sure that you're always filling the pill box based on the list and not the pill bottle directions. Adherence is very important after your transplant, so you should never intentionally skip a dose on purpose. We give you some instructions on what to do in the event of a late dose, or if you forget to take your medicine, and that will be given to you in detail at the time of your discharge. And then making sure you are always talking to the transplant team before you start a new medicine, and remembering that Tylenol or acetaminophen is the only safe over-the-counter pain medicine. Everything else that's labeled for pain over-the-counter is not safe for the new kidney. And that wraps up our overview of our transplant medications. So I'll be happy to answer any questions that anyone has.
Thank you so much, Giovanna. That was amazing. We definitely have some questions. Our first question is, how many medications on average does a transplant recipient take after 1 year?
I would say it kind of depends. So at the 1 year mark, you should be off of all your anti-infection medicines, but the anti-rejection medicines, like we said, are for life. So you'll at least be on 2 or 3 of those. And then it depends on what your other disease states are. If you have diabetes, high blood pressure, and we're managing all of those medicines, because we don't, the only thing that we fix with the kidney is all of the kidney problems. So if you were on other medicines prior to transplant, we don't necessarily fix those problems with getting a new kidney. So more than likely your list would be longer if you have some other disease states that we're managing as well. So
Right.
It definitely varies.
Right. Yeah. So it's a tailored to each person. And luckily every person is getting education prior to leaving the hospital and follow up very closely, especially that first year. Fantastic. And then another question we have is, if there's a medication that's causing like an immense amount of GI upset, or patients are struggling to keep that medication down, do you guys work with the patient to try and find an alternative route or method? Could you talk a little more about that?
Definitely. So the slides here and the instructions here is like our generic cookie cutter medicines, but everything is patient specific. So if there's a side effect or a reason why a medicine is not working for you, these are not the only medications that we have available to either prevent rejection or prevent infection. So you should be open and honest about whatever you're feeling after the transplant, even if you don't know if it's caused by a medicine or whatever it is. Just whatever you're feeling, you tell your transplant team, and then it's our job to figure out if it's a medicine and how we can adjust the medications to increase your quality of life, because the transplant should be improving that, not making it worse.
Right. I think that's really important, because it can be, it can be daunting to tell your team that you're having all of these side effects and then feel fearful that maybe, you need to just kind of grin and bear it. But talking with your team when anything feels off is so important, even if it's, beyond medication. If you're feeling like mentally something's off, you contact our team and we'll, work with them. We'll wait for folks to submit some more questions. And while we're doing that, I'll go through just some of our follow-up resources that we offer at the program. This is just a list of really helpful websites that you can visit if you are waiting for a transplant and searching for a living kidney donor. Transplant Living website, the National Kidney Foundation, I can't speak highly enough about. They just have really wonderful free resources that are easy to digest. And it's also a really beautiful community. So if you have the bandwidth, I would recommend going to their website, getting involved. They have an annual kidney walk each year, which is an amazing event. And they also partner with us and host Big Ask Big Gives, which are living donor workshops and provide opportunities to learn about strategies on how to ask the big ask, which is, asking someone to donate a kidney to them. Transplant Outcomes is the srtr.org, and that's the site you can go to compare transplant centers, view outcomes, kind of data heavy resources, but always helpful. Findakidney.org is a new site that the National Kidney Registry created, and I'll talk a little bit more about what it can be used for, but it's the gateway to the microsite program. The National Living Donor Assistance Center is really for potential living donors, but I always tell my patients, if you are searching for a living kidney donor, you should know about what being a living donor entails, because you're going to be able to educate those about living donation accurately, and knowing what resources are available can actually help someone potentially consider donation if they don't know about it or have fears. So that's a good website to get familiar with. And then the American Transplant Foundation, another great resource. So we'll send these out to you post presentation along with the recording, so you don't have to take them down now. I think our next slide is about the Transplant Mentors program, which we absolutely encourage you to consider if you're looking for some additional support. You could also consider becoming a transplant mentor at some point down the road. If you've been transplanted, this is a nonprofit organization based out of Kansas, and we've been working with them. And so contact myself, or you can directly contact Patty Draper to get started and learn more about the program. And it's just a great free opportunity for you to get some more support. And this is about our microsite program. So if you're on our waiting list and you do not have a living donor, you should make a microsite. It's a free source that you can use to get the word out that you're looking for a living kidney donor. The website is created by the National Kidney Registry through their platform, and it has living donor education embedded. It has our registration system right on the website. I'll show you in a few slides an example, but potential donors can register directly to you through the site. And then patients can also get business cards sent to their home that they can leave in public areas. And you can see a sample right here. It says, I need a kidney donor, and you get a unique URL. So if you're interested in creating a microsite, contact myself, contact your transplant coordinator, and you'll see what a microsite looks like in the next slide. So you can see there's a photo, there's at the top, the bar shares the name of the patient and how people who are viewing the site can help this patient. So sharing the story through Facebook, Twitter, or email, people can see if they're qualified to donate, and they can just read a little bit more about why this patient needs a transplant and how much of an impact having a transplant will have on their life. There's more room for personalized photos. And then there's information on all of the donor support protections that the National Kidney Registry offers. This includes wage reimbursement. This includes more information on the voucher program. There's a lot, and it's simply too much to even explain on this, but learning more about these protections for the potential donor is really valuable because, again, if you are speaking to someone about living donation, maybe they've never even heard about living donation and they have fears about what it entails. You're going to be able to talk to them confidently about what it means to be a living donor. The fact that you can be a living donor as a healthy person, we can live with one kidney, and there's donor support protections. So it's a really good resource to get familiar with. Next slide, we have another simple site, a great one. They're just warm and inviting. So I really encourage everyone to make a microsite. And chances are you found this webinar through our social media channels, or you got an email, whatever way it may be. Join our social media community. Our Facebook page is really great. People really support one another. We share stories. We share events. We share education. We share updates to policies, changes in the transplant community. So follow us, drop a comment. I'm the person who runs it, so I'll always respond. And yeah, thank you so much for joining our webinar today. We did just get another question. So how long are you quarantined after transplant while your medications are being adjusted?
Yeah, so that's a great question. Generally, we tell patients like 3 months is when you'll get back to like your normal, like you'll get back to work and all of that. So I would expect a couple months where we tell you that you need to avoid public transit, staying away from like overly populated areas. And then you should be practicing the same precautions that we were all doing during the height of COVID, as far as wearing a mask, washing your hands frequently. Nobody's coming around as far as like family members and friends that are sick. Little kids that have the sniffles are staying away from you. It's usually a couple months.
Yeah. Thank you, Giovanna. Keep the questions coming. I'm just going to review our website, weillcornelltransplant.org. On our website, we have an education center. We also have more information on the medications that Giovanna was speaking about. There's actually a very nice series of videos that explain the medications. They're on the website, and we can share that link after this session is over. And if you want to just explore it, there's a lot of information on there. So that's our website. And yes, so next session is transplant nutrition with our registered dietitian, Mike. That is going to be a wonderful session because so many people have questions about their diet and how things look after transplant and what they can have. And it's just a really popular session. So please join us on July 25th and July 26th at 11 o'clock and come ready with some questions, and we will be able to answer them. So thank you so much, Giovanna. It was really insightful lecture, and I love how you really broke it down and made us all understand. For those of us who aren't pharmacists, I thought it was really digestible. So we appreciate you taking the time.
Of course. Thank you guys for having me.
All right, guys. Well, that's a wrap. See you later.
Thank you so much, everyone. We'll see you next month.
Okay, bye.